if you want, I can start, and then Ramesh, whatever you wish.
Yeah, I don't mind, Adrian. So you go ahead. You probably.
Okay.
So it's our pleasure. Welcome, guys. Where are our two hosts?
I told you about Dr. Gauhar.
Imad Kanan, did he come in?
No, he has not joined it. He's not on the list right now.
Let's see.
Okay, so let me know when you want me to share my screen.
Oh no, he's just 1 second. Imad is saying, send me the link. I didn't have the proper link. Imad, did you send me the link? Imad, can you send me the link again? Oh, I have it here. I'll just forward this to him. He's just coming in.
So in the meantime, what happens, Salman, if a patient has pituitary apoplexy and he's, in bad shape, and therefore he needs to go like right away? And I mean, you have to. How long does it take for?
6 hours to get the COVID test.
So I guess you could still hold them up for a little while, right?
Yeah.
Well, we have a like a rapid test as well. On the day they get tested, and that results comes back within 2 hours. So that is the second test is often a rapid test for us. Yeah.
Okay.
Yeah, I think it's common sense that you want to take risk of all those people, your staff and everybody, because for example, now at the moment there are 6 people in our staff who are on isolation because of being exposed to a patient. Patient came in, we did a COVID, arrested, had a CPR. People did CPR on him. CPR you should not be doing in a COVID positive patient because you get fumes all over the place. Max you can do is shock them, but you should not do CPR.
I read somewhere that in a pandemic, there are no absolute emergencies, that the chance that you're going to revive a patient who just went into cardiac arrest with COVID, that you're going to bring him back, is close to 0. So why would you expose yourself and the rest of the team?
Yeah. So obviously this patient came in, we did not have COVID back. We sent the COVID, and patient had a dorsal spine fracture, arrested. The people did CPR. So all those people are now, I know, isolation, will have tests at day 5 and, blah, blah, and all the occupational therapy follow-up, etc. So all that is obviously, is there for us. So let's see if Imad Kanan has he come in yet?
I think I can share my screen. I think I'm able to share my screen if you guys want me to go ahead.
Sure. Go ahead and share your screen in the meantime.
Let's see. Okay, can you guys see my screen?
Yes.
Okay, so I'm just going to go ahead in the meantime. All right. So good morning, good evening, and good night to everyone around the globe. I really would like to thank Salman and his great team for organizing these talks. I was requested in order to deliver a talk on basic principles of endoscopy and how to stay out of trouble, complications. So I'm just going to do that, and I'm going to go over some constant, So the basic elements for neuroendoscopy: you need to have optics, you need an endoscope sheet with working and irrigating channels, you need proper illumination, and of course, everything that you're looking at and doing should be captured by an imaging device. You also need to have irrigation, Fogarty neuroballoons, instruments, and an endoscope holder. This list that I have put here, I think it's the minimum that you should have in order to perform the general and safe procedures in endoscopy. So, as you know, there are many configurations of lenses. There are lenses that look some, in a 90-degree angle, some are on an open angle, some are straight. What you should have in mind is that in any of these configurations, the best choice is to have the camera, which is quite heavy, away from your hands, and positioned in such a way that the fulcrum that the camera will perform because of gravity will make the endoscope easy to handle, and it should not have drift during the procedure. So that's why endoscope holders are quite useful. So there are basically four types of endoscopes. The first one is the classic system in which there's air with some glass rods in between them, and the image just basically bounces within the tube. And then there's the second system, which is now the most common one, in which specially designed glass rods are placed, and there's some air in between them, so the image is amplified. This is the so-called Hopkins, and these can come on a zero angle or various angles. We'll see that. And there's a fiber optic in which a bundle of fibers will produce an image, and it will be carried back, and then basically your camera will put all these tiny dots together and generate an image. And now we have what we call the flexible endoscopes, which have a chip in the proximal portion of the endoscope, which allows you to see directly. Of course, these devices are still under development and are quite expensive. So this is just for you to remember that there's the conventional system and the Hopkins, which I was telling you. And then there's a third one, which is called the green, which is a glass tube that has been somehow tailored to have this image bouncing around within the glass elements of the rod, and then you can end up with an image on the other side. As you can see here, there are different angles that you can have now with an endoscope. We even have the chameleon system, which is produced by stores, where you can manually shift the angle of vision. You should always mind that in order to have all these different vision fields, there's a price to pay that comes with magnification and distortion of elements. But it is, in practice, what I recommend is that you should start sometimes with 0, sometimes with 30, and pretty much you will get used to it. Your brain will adjust to the image. You will learn, like in anything else in neurosurgery, to adjust your relationships in space. So you should know that depending on whether it's a 0 lens or a 30-degree lens, the closer you get to an image, you have a magnifying factor. And of course, the bigger the lens, the bigger and the image. Sometimes you go into a general surgery room and you see how they're doing endoscopy with these big rods, and they have this huge vision and very defined. And of course, sometimes we use tiny endoscopes to work within babies' brains, and sometimes the image is not as good. But I think all of this is rapidly changing as technology is getting better and better. This is the principle of how you put together the image on a fiber optic endoscopy. So it's a number of rods that conform the image. The problem that you have with optical fibers is that as the endoscope bends back and forth, with time you'll start to see these black dots in your image, which means that the fibers have broken and are no longer transmitting the image. So they decay with time, and eventually you need to replace them. Of course, the other choice that I show you, which is the camera in front of the flexible endoscope, it's a very nice, but also very expensive. So these are two kinds of flexible endoscopes. And you also have rigid optic fiber neuroendoscopes. These are manufactured by Medtronic, and they're so-called disposable. Some of these will even allow you to stick the endoscope within a catheter, so you can drive your ventricular catheter as a sheath, and then protrude the tip of the endoscope. And once you have placed your catheter in the desired position, you basically pull out. The price to pay with these kind of endoscopes is that image, to be honest, it's not so good, but you always get used to it. So endoscopic lens sheets will enable you to put in a lot of instruments, and we have large working channels. You can see here, this is the MineUp invent system that was designed by Esculap. This enables you through this oval channel to put dissectors and a number of scissors and different coagulation elements. This is below it, the other system, which is also very common, where you have various tubes. And then you have what we call the space scopes. The space scopes are a lens that it's contained within a sheet. So basically, you can keep the sheet in place and you can retract and protrude with the endoscope within the sheet, which enables you to work on a confined space. More on this later. Um, most of these working channels will have trocars, which can be fenestrated or not. And also you have channel obturators, which enables you to maintain fluid volume within the ventricle. Always, whenever you're starting an endoscopy, be mindful that whenever you're using a 0-degree angle, there's no protrusion of the lens through the sheet, whichever sheet it is, so it's flat. But whenever you're using a 30 or more degree angle endoscope, in order for you to have this field of vision, the tip of the lens will protrude, and sometimes instruments that come on the side will not be seeing into your field of vision until they're already 1 centimeter out. So you should always play with your endoscope beforehand. We have now several sources of illumination, and you can even perform autofluorescence or protoporphyrin fluorescence, which enables you to see vessels within the ventricular cavities, even confocal endoscopy. This is the camera, which is a charge-coupled device. It basically splits the image in the basic 3 colors, as the old TVs, the trinitrons, which used to split within the 3 colors, and each of them rebuilds the image. This is the gradual improvement that we've had in imaging. As you can see, before we had 480 by 7 and 20, and now we can have ultra 4K cameras and monitors to look at endoscopy. So be mindful that all of these procedures are taking place within a very confined space. So all of the configurations of instruments, endoscope holders, cameras, and illumination provided by optical fibers should be confined to a very small place, and it should always be comfortable to work around. So it gets a little bit of time to get used to it, but nevertheless, it works. So sometimes you have grasping forceps that can extend 70 centimeters away from your target point, and somebody else can manipulate them away from the endoscope. Or sometimes you basically insert a forceps or a scissor in this configuration, which enables you to work closer to the object, perhaps with a little bit of more control, but always you should have that your hands are really close to the camera and the lens. So that's a disadvantage. This is part of the system I was telling you about. This is the Minor Invent, and how you can actually put bipolar electrodes of several configurations and dissectors and scissors and so on. Of course, their use is limited. The balloons, as you know, are essential for dilating structures. Most of us use regular Fogarty balloons, but there's also the Neuro balloon, which is designed by Integra, which is a double balloon that you can use to dilate structures. Also, we can have monopolar coagulation, which nowadays is quite useful for choroid plexus coagulation. Of course, there's also bipolars, and each one of them will have particular uses. More on the several configurations of tools that you can use through an endoscope. And very important, doing endoscopy within a very confined cavity, such as the brain, requires you to be steady. So if you're doing a quick case and you have a big ventricular cavity, you can always do a freehand endoscopy, which can be single-handed. This is the OE endoscope designed by Storz, which you can hold in your hand. It kind of resembles the configuration of a gun. So you hold it with one hand, and with the other hand, you can perform all the procedures. Or you can use a holding device, which will hold your endoscope steady in front of your target. Of course, the holding devices are a whole more safer. and it will depend on the procedure that you're planning to do. More on this later. So if you have an endoscope holder, you can, put a number of instruments, you can perform a number of things, and you're actually quite steady. Okay, so what's new? Well, we have now 3D vision, particularly for cranial-based endoscopy for transsphenoidal procedures, which enables you to have very nice imaging. And one of the good things that we have nowadays is that, this 4K configuration enables you to have real clarity of vision and high detail on procedures that you're performing. And also, let's move on. The other thing I want to talk to you about rapidly is keyhole surgery. As you know, keyhole surgery enables you to enter through several corridors using very low-profile instruments and lenses. This is a concept that we inherited from Axel Pernesky and enables you to have an expanded field of vision within a very confined space. Supraorbital craniectomies are, being more and more common. We're using it more and more as we're getting used to this. And you can see that whenever you're using endoscope-assisted microsurgery, the level of detail and how you can turn around, this is a craniopharyngioma, see, this is the optic nerve, this is the olfactory nerve, the carotid. You can move around the whole area, and you can see corners that you would not be able to look around using the microscope. And the interesting thing is that as you get used to this system, you basically follow the vision, and so you move around constantly with your lens within a confined space, which would require you to be constantly moving your microscope, and that would be, a very lengthy procedure. But as we gain more and more experience, I think this is coming to be probably the future for many cranial procedures. Okay, so I think with that, we will finish the general talk on general principles of endoscopy. And now I am going to move on to the next talk. Okay, let's share this screen. Can you see my screen?
Yeah, we can.
Yes.
Okay. All right.
Adrian, I just want to tell you that Professor Imad Kanan has joined us.
Okay.
He's our host for today. Sorry, there was some confusion regarding the link. I apologize for that.
Okay.
Hi, Adrian. Hi, Ramesh.
Hi, Imad. Good to see you.
Hello.
Hi, all of you. Good to see you.
Hello, how are you?
Fine.
So I will go on. So we will talk a little bit about complication avoidance in neuroendoscopy. These are basically some analysis and things. So how do we define a surgical complication? We define it as a undesirable, unintended, and a direct result of an operation that affects the patient, which would have not occurred had the operation gone well, as could be reasonably hoped. A complication, the definition is very wide, in literature. You can have a complication that can be as minimal as abnormal scarring. You can have a CSF fistula. You can have intraventricular bleeding, neurological disability, and even you can have death. So it's a very wide spectrum. But nevertheless, it's an unintended, undesirable procedure. So Pepe Shinali in 2007 defined complication and he said that endoscopic procedures should be classified as successful when you don't require anything further, partial success whenever there's a primary objective accomplished, but then you're required to do something else, success, but you needed to reoperate for the primary objective, and then the complete failure of a procedure. This diagram shows you how you can actually have a number of barriers that have been devised in order to prevent complications. You can have a very good organization, you can have supervision, you have preconditions from the patient, and then you can do unsafe acts. And sometimes all of these things align together, and you have these Swiss cheese configurations that lead to an unintended complication. So what's the best way to avoid complications in surgery? Okay, so number one, I think a surgeon should be honest in the sense that you should know yourself, the limits of your techniques, the limits of your knowledge, and the limits of the information that you can retrieve from a patient. That's why nowadays, we have imaging, we have laboratory tests, we have neurophysiological testing, which all deliver information back to you and let you know what the state of the patient is. So having that into mind and having a good planning and performing a procedure should enable you to steer away from this so-called point of no return. Whenever you perform something that will invariably lead to permanent disability, or at least will put the patient in dire straits. So these are extreme decisions. How do you abort a procedure? Well, that means that you can have a cessation of an unplanned surgical procedure prior to achieving the pre-planned goals. And knowing the morbidity and mortality associated with a procedure will be the key factors to consider whenever you're trying to make this call. And you should always mind that aborting a procedure is not a bad choice if by doing so you prevent harm or the death of a patient. This is a very interesting paper that was recently published in Child's Nervous System by the group of Tel Aviv, by Jonathan Roth and Shlomi Constantini. I really would like to invite you to review it. All the decision factors, taking into account endoscopy as a model. So here you see we're trying to perform an endoscopy on a really, really scarred basal cistern. So even though you can master these techniques with time, if you're not used to them, if you don't have enough experience, or if you feel that by performing something you're jeopardizing the patient, you should abort a procedure. Also, look at this. We're taking, this is, as you get older and you start reviewing your images, when you started out, we were removing this metastasis that was within the floor of the third ventricle. And we are successfully removing the metastasis that was basically on top of the basilar. But then you realize, why should we endanger the patient by doing this? Are we proving something to ourselves that we're really good in endoscopy? You should know your limits, and you should be able to tell if you had a safer procedure. So we safely removed that, but of course we could have pinned the basilar artery. And of course we had a bigger lesion to resect where we could have a more adequate biopsy. So whenever you glance back, you see your videos, you see your images, sometimes you say, why did I do that? And that's when you start to accumulate experience that will enable you to make proper decisions. And also be mindful that if you have an endoscope, not everything should be done in an with an endoscope. You have many options. You should always do a good analysis of the case to figure out what the best choice for the patient is. So here are some of the aspects that Shlomi exposed to perform an ETB or do against an ETB. Perhaps the most important factor against performing an ETB is whenever you have non-favorable anatomy. Very small ventricles, a very small prepontine space, you have a thick floor, or your vision is not adequate. And also, there are a number of factors that are involved that are surgeon-related. Sometimes you have this self-belief that you can do a procedure and there's an acceptable risk. But you always remember that whenever you say, oh yes, I think we can take this risk. So who is we? The risk is basically taken by the patient. And sometimes you become adamant about what you're exposing the patient to. Also, sometimes you can feel that if you're aborting surgery, this could be a personal and professional failure, and that's wrongful thinking. If you're stopping a procedure in order to avoid injury, there's nothing that will substitute, a patient that awakes uh, better than how he was, or at least as good as he was before the procedure started. Uh, and of course, there's always excessive and inappropriate self-confidence. There's fear of colleagues, of how they're going to, the perception of that you avoided the procedure, the fear of medical legal actions. And very important, I think we heard a couple of days ago this extraordinary talk that was given by women involved in neurosurgery, the factor of a mentor, a surgical mentor that will whisper in your ear, it's now time to stop, it's now time to perform this other procedure. So the expectations of the patient, there are many factors that are involved in this. So here is when we come to define what an expert is in surgery. The definition of an expert, in my point of view, is that surgeon who has either experienced himself or has witnessed every single complication related to a procedure, right? Of course, you need to have some gray hair on your head to claim that you have seen almost everything associated with a procedure, not only in your hands, but in the hands of others. And you have learned how to deal with all of these complications, but most importantly, you have learned how to avoid it. That's the definition of an expert. Um, and also, it's capable of teaching others how to prevent of reproducing such complication. This is expertise. It's not the guy who performs the best clip of an aneurysm, who resects the tumor best, but knows what the boundaries of technique, the boundaries of anatomy, and the boundaries of the physiology of a patient that can tolerate any procedure. So, of course, there's a learning curve. Most of us are really, really related to this concept of the learning curve in medicine, where you basically slow, you accumulate, and then you come to a plateau where you finally think you have made it. Of course, this requires time. And, airplane pilots and a number of other professionals spend many hours in front of their simulators in order to perform surgery. And if you compare that to what happens with, let's say, intraventricular endoscopy, basically you practice every single time you go into the brain. So the amount of time it's non-comparable. Musicians, they perform a lot of practicing, a lot of hours before they finally deliver their concert. So how is it that we can excel in surgery? How can we practice? That's how we build models. But nevertheless, anatomical models in endoscopy have not been as good as we have wished. Cadavers are not as good as we would like them to be in order to work. Animal models, they resemble tissues and they give us an idea of how to handle yourself, but they do not reproduce the disease. Um, and of course, we have a number of workshops worldwide where we try to reproduce the circumstances and teach endoscopy. But the most important thing is that the comparison of risk in healthcare as compared to some other human activities is very high. The chances of hurting a patient and the lives that are lost every year through medical procedures are far greater than commercial aviation, nuclear power plants, and chemical manufacturing. So this is something that's time dependent. So you have to spend a lot of time practicing and practicing again. And most of the time, the so-called learning curve has this dip. Initially, you start gaining confidence, and then you come to a point where something bad happened, and then your confidence goes down, and then you realize and analyze the factors that led you to a bad outcome. And you start doing the procedure again, you start getting better, and finally you get this secondary learning curve that enables you to deliver good results to your patients. So how do you measure these outcomes? You can measure them through post-op analgesia, to a lesser infection rate, to the less need of transfusion, to the duration of staying in ICU or general wards, the morbidity or the mortalities, and the cumulative survival rates. And also the operating time, the use of equipment and consumables, the blood loss, the radiation exposure, or the technical adequacy of any procedure that you perform. So I think this old motto that to be or not to be, that is the question. Always remember that you can be the surgeon who's holding someone else's head, but this can be your patient. You don't want your patient to end up dying. So you have always many options to take. And we would always would like an endoscopic procedure to go, seamlessly and to expose the basal cisterns such as this. But sometimes while you're doing surgery, and you're especially practicing on the patient, this is an transsphenoidal procedure. They're exposing the loop of the carotid, and as you can see here, they're carefully removing portions of thin bone around the optic chiasm and the carotid. And it takes just seconds for you to, even being very careful, that you can lacerate a vessel and end up with a very bad outcome. So, and also there is a question whether there's an appropriate indication. We discussed a few days ago the need to perform endoscopy in cases such as this is a cavern septum pellucidate that is producing headaches. Some people might claim this is something that you can operate. Sometimes claim that you should leave it alone and headaches will go away. So you should always review the indications for a procedure. This is also CPC coagulation. This is, as you can see, as years have gone by, this is becoming more and more common. But we actually don't know what the outcome will be of, taking out the cord plexus and the multiple neuroendocrine secretions that are produced by the cord plexus and the impact in child development. So many of the things that we performed a few years ago now are gone, and surgery constantly adapts. Okay, so the other thing is that you should always be mindful that we perform endoscopy many times in order to avoid a shunt. And a shunt is not always the devil. A shunt is a good thing for many patients. So if you're not feeling safe, if you think that performing an endoscopic procedure will put the patient in risk, you should always abort and transform the procedure to a shunt. Most of the time, the patients do well. We perform endoscopy in order to try to avoid putting in a shunt, but not all the time you are successful. So complications in endoscopy, it has been called a complication rate of 6 to 20%. Always remember that we as surgeons tend not to report our complications, but we need to be honest. It has been estimated that the global rate of complications in endoscopy is somewhere around 8.5%. 4% lead to a procedure termination. And you can see here that less than 1%, 0.21 is the most feared complication, which is the basilar artery lesion. And you can have permanent sequelae. And here, and there is that Latin aphorism that errare manum est. So you can always claim that failing is human. But the other part of this sentence that we usually do not quote is perseverare autem diabolicum, which means to err or to fail is human, but what is really diabolical is to persist doing the same mistake over and over again. So always learn from your mistakes. So what are the factors that can contribute to bad outcomes? Well, sometimes you are inexperienced. Sometimes you attempt to perform a procedure that's not indicated for the disease. But sometimes these factors are away from your hands. Sometimes you come in the middle of the night and the nurse that's on call, it's not your neurosurgical nurse. She hasn't seen the equipment. This is the first time she's looking at all these weird instruments. And I will bet that every single one of you has encountered this phenomenon. You came in, you're ready to do a procedure, and the scrub nurse is not really aware of all the parts that you need to use or all the steps. Sometimes you perform a number of procedures throughout the day and not all the equipment is available. Sometimes not everything is sterile. Sometimes the optics and the monitors, there are electrical devices. Sometimes they fail, they malfunction. sometimes at the start of the procedure, in the middle of the procedure, as you were about to end, something went on and power went away. The position of your endoscopic tower, the position of the patient, the endoscopic holder, the type of endoscopic holder, these are all contributing factors that, as with any procedure, you should always perform a good planning of what is it that you're going to do. So always review the indications to rule out poor factors of bad endoscope outcomes. So for instance, patients that are less than 3 months of age, that are low weight, that had a history of intraventricular hemorrhage, that have small prepontine cisterns, these are patients that are not good candidates for ETVs. And always plan B, as I said, for shunt insertion or open conversion. So are you familiar with the case? Are you familiar with the proposed technical procedure? Do you have your images at hand? Some of these things sound very silly, but these are real daily life problems. You come into the room and sometimes the images are not there. The PAC system is failing. The images that you're looking at are not the most recent ones. You're looking at a scan that was from a few months ago. So if you have navigation, by all means, do not hesitate to use it. It's very common when you're doing endoscopic procedures that are different from ETVs, or even in ETVs, that sometimes you're lost within the ventricular cavities because anatomy has varied. So if you can use it, always be mindful of this. If you're putting fluid into the brain, always remember that what goes in should come out. And the temperature irrigation solutions should always be at room temperature. Test all the electronic equipment. One thing about irrigating solutions, back in the day, we were told that only Ringer lactate could be used. But now we know that you can use saline safely, and Ringer's lactate, and both of them work as well within the ventricular cavity. Of course, any other solution should be avoided in order to not to expose the patient to hypertonic or hypotonic solution. Again, all the instruments that are going to go into the brain, before you put them in, please open and close them before you put them in. You will be surprised at some point that you stick an instrument, you grab the bite of a tumor, or you grab the vessel, or you put a scissor, and all of a sudden it didn't want to close. It's stuck. So you should always check that it's well lubricated, that it's not bent, that somebody didn't twist a little bit of the instrument and now it doesn't want to close or open properly. So how do you want to insert your endoscope? You can use it first by using a ventricular catheter in order to track your way into the ventricle, or you can use a neuroendoscopic throker such as these. They're called peel away. Always be mindful that there are depth guides, and that something that is greater than 5 centimeters, it's probably not close to the ventricle. Never go beyond 7 because you're coming really close to the base. And very important, the part of an endoscopic procedure where patients are more prone to be injured is basically this initial step. When you insert your endoscope, and you're looking for the ventricle, and you have this rigid metallic tube, and you end up either in the basal ganglia producing permanent injuries, or you end up somewhere else and not within the ventricle. So using a ventricular catheter or using neuronavigation, it's a good idea to access the ventricle. Also, you can rotate any of these structures, so you roll away vessels away from the tip. And always remember, when you're doing a borehole, you have very little control of what happens below you. This is just a tiny window into a big universe. So what are the factors that live in a good image? So are you seeing the real thing? And I'm quoting this because there have been legal cases. Charlie Teo told me some years ago that he had to act as an expert witness in a case. There was an endoscopic procedure where somebody was getting an ETV, and the image, the camera, the tower, at that time, you were able to either reproduce or record the cases. So somebody pushed the play button and you were seeing exactly an ETB, and the patient, of course, this was another patient, and the surgeon was inserting the scope into the patient, and he was saying, hey, this looks really funny because, it doesn't match what I'm doing. And of course, the patient ended up in a disaster. So always, are you seeing the real thing? Is your camera well oriented? Is your system well coupled? Do you have a damaged or foggy lens? Sometimes there are blood deposits or there's debris in the tip of the endoscope. And sometimes you have active ventricular hemorrhage that precludes a good vision. This organization of how to look into two monitors into your endoscopic field is something that we have learned from performing transsphenoidal procedures, that nowadays we use it even for intracranial procedures. Two monitors is a good thing. Always someone has to be looking at the monitor, because it's very common that as you take a biopsy or you're inserting a Fogarty balloon, everybody wants to see how the little thing goes into the endoscope and steer their vision away from the operating field, which is your monitor, into the endoscope. And in the meantime, things go shaggy in there, your endoscope moves out of place. So be careful with that. How do you plan your point of entry for ETBs? This is a system that, or a procedure that was described, that you basically put a line from your target to the most posterior portion of the foramen of Monroe, and the most anterior, you draw a triangle, and in the middle, you put basically your borehole to go into the ventricle. Sometimes as you're performing endoscopy, you go into the ventricle and you will find debris and blood that precludes your vision. If you're not comfortable enough with this, if things are looking really foggy, if there's bleeding that comes from elsewhere and things start to get foggy, you can irrigate, but if that is not helping, this is a patient in which we are irrigating and vision is getting worse and worse, you should consider that you can always step away and put a shunt in these patients. Sometimes, as you're performing endoscopy, debris gets in the tip of your endoscope, it goes away, it comes back. So you have to clear all of this in order to have a good vision into your ventricular cavity. Let's see. Sometimes, whenever you're performing a biopsy, you can always have massive venous bleeding, which precludes you from seeing adequately. And most of the time, the most normal reaction when you see bleeding big time is that you want to pull away. So stop, irrigate, and be patient. Most of the time, if you're able to irrigate and get a little bit closer to the source of bleeding, you can actually see what's going on. But if you pull away, you will never be able to locate that area again unless you have neuronavigation. So we can have transoperative complications with some vital sign changes. The most common one is tachycardia, but most of these changes are usually transient. This is navigation. And of course, remember, anatomy is key. All these beautiful images of how the cisterns and neurovascular structures in the basal cisterns are, you can always study them, but remember that the disease never studied anatomy. There is a very high chance that your never will look like these beautiful illustrations that you saw in Netter. You open these books and you see these beautiful drawings, but disease is very, very different. So study the patient well, use your neuronavigation. Many configurations of the floor of the third ventricle can be seen in patients with spina bifida. Positions of the artery within the cellar floor, the floor of the third ventricle can be seen. I'm just going to go over very quickly for the sake of time and the next speaker, but you can actually see vessels that are actually located very differently in abnormal positions. You can see here the basilar artery running across all the floor of the third ventricle. So pathology did not study anatomy. Complex diseases such as myelomeningocele, subarachnoid space tumors, and model-loculated hydrocephalus can distort your anatomy. Also, if you're working within confined spaces, you should always remember that going in there is not always easy. Scarring is a very bad enemy for optical navigation. So neuronavigation will enable you to define structures. This is the floor the floor of the third ventricle in a patient who experienced intraventricular hemorrhages. So it's very hard to tell what is what without neuronavigation. And I think that for the sake of time and the next speaker, I'm going to stop there, but I'm going to give you an extra tip that sometimes whenever you're performing surgery and there's a vessel that experiences bleeding, you can get close to the source of bleeding, and then you can retract away the sheet of the endoscope whenever you're using a channel scope, and you can start irrigating and isolating the point of bleeding. So gradually you wash away the blood that's in front of your lens, and then you can coagulate the area that was bleeding. Of course, this takes a lot of nerve and patience, but once you have isolated the vessel, you can coagulate what's in front of the tip of your endoscope, and you can basically pull away. Same happens for some tumors that are bleeding. You can actually transform them to dry field technique, and you can also stop bleeding by doing this. So let me see. I think I'm gonna stop there in the interest of time. I think that the key answer to this is that always be mindful of your technique, know your instruments, know your patient, and know yourself, and you should be able to stop in order to prevent ETV morbidity. Most of the time, morbidity is transient, but you can have some permanent morbidity that can harm your patient. So I think I'm going to stop there in the interest of time, and we'll let Ramesh deliver his conference.
Well, thank you very much, Adrian, for a wonderful presentation. You cover many aspects of it. There was one question from the participant, but you answer it. If a major clot happens at the endoscopy, and you mentioned you should not back up and just irrigate and wait, you always have the chance to control it. That was the question. Came from Muhammad, but he didn't specify from where he is.
An additional thing that I would just like to comment is in the case that we saw that there was bleeding from this injury to the carotid. This is the group of Danny Prevedello. He provided this video. They were basically able to pack the injury with muscle, and then later on, always when you have these kind of injuries to the carotid, you should always look for pseudoaneurysms later on. Sometimes they will require embolization, and sometimes just by gentle packing with muscle, you will not have a pseudoaneurysm. But always be mindful that this is an injury to the vascular wall of the carotid. So I think that's it.
Wonderful. I have one question. What is the rate of that you have to convert to a shunting procedure as a failure for ATV in your practice, roughly?
I think nowadays, as you know, as we're gaining more and more experience, I would say probably out of 10 endoscopic procedures, sometimes maybe one. When we went in there, because now we're trying to push the boundaries of endoscopy. You know, we're trying to perform endoscopy in children that are lesser than 6 months of age, and sometimes, you know, we have this philosophy that if you can avoid a shunt, that's a good thing. And every single patient that comes in that has a block shunt, will try to perform endoscopy in order to see if we can, you know, give him this benefit. But sometimes you go in there, you open the floor of the third ventricle, It's very thick, you have no flow, and then you basically abandon the procedure and say, why should I persist? It's very evident that endoscopy will not help this patient, so I'm just go back and replace the proximal catheter, and that's it. So that's our most common scenario now for stopping an endoscopic procedure. Of course, sometimes we go into the ventricle and we have bleeding from the wall or from the fornix that was unexpected, but this is becoming less and less common.
For a hybrid use of endoscopy with craniotomy, like a supraorbital approach, a keyhole, I realized you are using the holder for this one, and I understand it. What is your experience with the pneumatic holder that Berlinski used to introduce in his practice?
In our
What kind of
department,
problem you have? Did you use it, and what kind of problem you have?
we do not have the pneumatic endoscope holder. We have the rigid one, which has a learning curve, because the rigid endoscopic holder, you have to relieve the pressure by turning the knob. So the resident has to be very aware that there's a point where if they turn it too fast, things can actually fall into place, right? So the pneumatic holder, I have used it and seen it in workshops such as the one in Naples. It's a very nice device, but obviously not everyone has it. And then there's also the free, the handheld technique, in where somebody is holding the scope and you're working with both of your hands, such as how you would do in a transsphenoidal procedure. So I think every technique will have its indications. Sometimes we are refrained by cost or by availability of equipment.
Thank you very much, Adrian. We move now to Dr. Ramesh Nair from England. He's going to talk about steps in the section of a meningioma, his recommendation, and how he does it. Ramesh, are you with us?
Yes, thanks, Simad.
Okay.
Thanks, Salman, for this opportunity. And Adrian, as that was a great talk. I particularly liked your definition of expert and we reflecting on the complications. So an expert is someone who has seen most number of complications. And I read somewhere that the most handsome surgeon is someone with the most number of scars. So we all have all burned our fingers. That's how we learn. I think the best thing is to learn from others. So thanks for that talk.
You meant scars on him or on his patients?
It's the scars in the mind from complications.
Okay.
Yeah.
Go ahead.
And okay. So I'm going to start sharing my screen. And Imad and Salman, do let me know when you want me to stop. At least give me a 5 minutes warning, then I can share. Okay. So I would like to emphasize few points which I have often thought about in meningioma. So it's not something, it's not an exhaustive description of meningioma resection which you can get from many books and lectures. I would like to talk to you about some of the meningiomas and the way I approach it. So Salman asked me to ask the participants some questions during this talk. This is a man in his late 60s, an Afro-Caribbean man who I operated almost 8 or 9 years ago, came with cerebral symptoms, worsening progressive symptoms. So if I ask you, do you think it's a complex tumor or a standard meningioma excision? I don't know what the general opinion will be about this case. If anyone wants to answer, I'm happy to unmute that person, or Imad or someone can unmute that person. So for me, it depends on the epicenter of the tumor. So I would say it's not as complex tumor as some of the other tumors can be. For me, the one of the criteria, one of the crucial point about some of the complex tumors is the epicenter of the origin of the tumor. So essentially, that determines the way in which the tumor grows, and it then tends to shift the cisterns around, and that tends to determine its respectability. There are many other factors, including the auricular plane, which we'll come to later. But often think about, go back in time. We think about our time, going back to original humans and Earth and universe and all. But when you see a tumor, think about where the starting point was, especially in skull-based tumors. You can see that the tumor arises from the arachnoid capsules, from the pachyonic granulation, and then they tend to grow gradually over a number of years, displacing the cisterns around it. As you know, these tumors can invade anything. Now, they don't have meninges or some even prime structures do not have any impunity to this tumor, even the vessels, but often they respect the arachnoid. And if you know the cistern that is displaced, and that gives your a strategy in terms of tumor resection. All our nerves, including vessels, are wrapped around in cisterns. So you can consider these cisterns like a bubble wrap for our brain. Even when these vessels, they become arterioles, and when they enter the brain, they even carry a little bit of CSF around them. So you see, everything is wrapped with cistern. So that is what we have to utilize. So think about that point. And that case I showed you, you can see it wasn't the CP angle. I'm borrowing a slide from Roton's book. And also all these figures you see in this lecture are from online resources, and I thank them. So if you look at, we are inside the posterior fossa, looking at the right internal acoustic meatus. You see this internal acoustic meatus with this the vestibulocochlear complex and the facial nerve going inside it. So tumor, depending on where it arises, makes it more complex, especially if you're approaching from a retrosigmoid approach. Tumor behind it, they're not that difficult. Tumor above it, especially from the suprameatic tubercle, they're not that difficult. Especially the tumor coming in front of it, they may make it slightly more challenging, but if you take a different approach, it may not be that difficult. But tumor more medial to the fifth nerve can be a bit more complex. And these tumors can be classified depending on their origin. And that the site of origin of the tumor makes a big difference and the complexity of the approach. For example, if you analyze this tumor, one thing when you look at these tumors in the MRI scan to find out where the pedicle is, often you can find out from the MRI scan, often T1 or T1 contrast, or even T2, sometimes you can see the pedicle of the tumor, where they are coming from. And also the other factor we will talk about later is the arachnoid plane around it. So here you can see the tumor is close to the internal acoustic meatus, but it seems that it is probably not attached to the IAM as such, but it's coming from the, let me just move this, okay. So it's coming from the superior lip of the internal acoustic meatus. So you see that is where it started. And so it would have shifted the nerves down below and anteriorly. So that makes it surgically less risky. So there's no minor surgery. I mean, I say it's not complex, but there's no minor surgery. These are all major operations. Don't take me wrong. And I remember someone was asking a resident in a book, what is a minor operation in a neurosurgery? And the answer is, the only minor operation in neurosurgery is the one someone else is doing. If you're doing it, it is major, irrespective if it's carpal tunnel or something else. So everything is major, but compared to the complexity of some of the tumors, these tumors are not that bad. So you look at the attachment here. These vessels are coming off it. That is the attachment. And that determines complexity. See the CSF space around it. These are the things which you look for. And if you imagine the posterior fossa, the arachnoid is being peeled away, but when the tumor grows from the petrous ridge, dura, it tends to push all these nerves to one side, which includes the arachnoid. So preserve the arachnoid, and arachnoid is your ally, as Almaty said. And even the nerves higher up, when they go through the temporal notch, they push up the nerves higher up, and the branches of the superior cerebral artery as well. And so they are not at risk if you dissect them off carefully. So these branches, they are not at risk if you preserve the arachnoid plane. They may look daunting, but they are easy to operate. The other thing which I just wanted to show you is that this is another meningioma, not the one I showed you. when you open up the posterior fossa, the position should be such that you don't really have to put retractors in to retract the brain. And with the gentle movement, you should be able to retract it. And there's no need to injure the brain. In big tumors, you may have to go down to the cerebellomedullary cistern to let the CSF out so the brain can sag down. And my way of protecting the brain is to use patties. But before you use patties, I often put layers of Surgicel like this, because sometimes when you do long operations, the cotton patty can get dry and can be very hard. And when you peel them off after a big operation, then you tend to get bleeding from the surface. Then I use patties over it. And this is that case which I showed you. And the principles of meningeal resection is, as we all know, is the detachment of the tumor. The 4 Ds, which I often talk about, is a detachment, and that comes with the devascularization. So detachment and devascularization is a simultaneous thing. As you go along the base of the tumor, which is possible in most cases, but not possible in all the cases, often you may have to debulk and then do the detachment. But it's a combination of things, detaching and devascularizing the tumor, and then debulking and dissecting the tumor. These are the steps of meningioma. That's the key principle of it. And depending on the location, you have to mix and match these techniques. So when you encounter bleeding here, it is not a bad thing. That means you're only cauterizing the bleeding that is applying the tumor. So as you finish off the attachment of the tumor, so you may encounter severe bleeding, especially in some of the skull-based meningiomas, because they are supplied by various meningeal branches and even some branches from the internal carotid artery, giving the meningeal supply. But they can be stopped unless you are operating near the petrous and then going near the carotid. These are not difficult bleeders to stop. So again, this window is coming. Anyway, so that suprameatric tubercle is sort of detached from the tumor, which was the origin, and then you finish the procedure after that. And so there's no tumor seen here, but he did have a tiny remnant at the front. He being fairly healthy, and he didn't have any deficit at all, and they're still watching him for recurrence for a long time now. Another one, complex or standard, it's medial, more medial than the one I showed you before. And there is another one in the back that's fairly straightforward. But the one here is in front of the internal acoustic meatus. But again, if you come from the top, Salman, if I don't know, your secretary there, Imad, is there are some messages on my screen about admitting participants, and that's blocking my screen. But if someone can,
Imad, can you please fix that so that those messages does not come to Ramesh, please?
Yeah, not Imad Kanan. Imad, I'm talking to the other Imad who is working for.
Yeah.
Imadullah.
Imadullah, yeah. So
Yes,
so,
sir, I'm that.
So this tumor, as you can see, attachment of the tumor is in a narrow pedicle, and it is in front of the vestibulocochlear and the facial nerve complex. But it is something which we can go from in front of it and then detach it. So it's not that difficult. So that's what really we have to look for. And once you resect off the meningioma, you should not take off the meningioma with the arachnoid layer, thereby damaging the microcirculation of the pons and the brainstem and the blood vessels. You can see that's the left side, the tendorium is here. These are nerves, the 4th nerve higher up there, the 5th nerve higher up there, and the 6th nerve, and the facial and vestibulocochlear complex here, and the lower cranial is down there. So you have to preserve the microcirculation to all these nerves. And the meningioma excision should not involve you peeling off the arachnoid from these structures. So what about this one? Is it a complex tumor? It's a sphenoid wing meningioma. So the complexity is determined by its location often. And this tumor, this is a lady who I operated several years ago when she came with the features of raised intracranial pressure. You can see a lot of edema around it, and possibly it is into the sylvian fissure as well. But what determines its complexity? You have to study these scans carefully. You can see that Imadullah, could you just remove or meet John Bennett, who is popping up on the screen?
No, sir. He is not John Bennett. He's someone else.
I can admit. I think maybe it's best that I do it myself. I can do it myself. Don't worry. So this is the MRI scan. Okay. So I'm just going to. So this is the meningioma, which is intensely enhancing, so that you know that it is a well vascularized tumor, and so this is, see the pedicle. See, it's away from the clinoid. So when the attachment goes towards the clinoid, it makes it more and more complex. This attachment is away from the clinoid, and you can see the vascular pedicle there. So it should be a fairly straightforward. But one thing you have to be careful about in these tumors is this proximity to the sylvian fissure and the MCA branches. And once you resect off these tumors, sorry, let me just see if I. So this is the left side. After excision of the tumor, you can see the lateral. That's the anterior clinoid here, and you have the anterior petroclinoid fold coming here, attaching to the anterior clinoid, and the internal carotid artery comes here. Just let me fast forward a little bit. So the carotid artery and the olfactory nerve is here, and the optic nerve is in front of the carotid artery. This is the left side, and so that is the. Let me just bring it forward. So that's once you expose it, then you see the PCOM, and then you can also see, you move further below, you could see the third nerve. So the anterior petroclinoid fold is here, and let me just expose it a bit more. So that's the third nerve, which exposes the oculomotor trigone. The point about these sort of operations that when you try to drill the clinoid, when you really want to coagulate the base, you've got to be careful, especially in this location. Sometimes the heat can get transmitted, especially drilling of the clinoid. The third nerve from here, it goes under the clinoid here before it goes into the orbital fissure. So that's the posterior clinoid, and that's the Peters apex. So you have an anterior petroclinoid fold here, then you have a posterior petroclinoid fold, which is hidden by the third nerve here, and that's the posterior clinoid. So this is the oculomotor trigone, and also it carries a cistern around it. So the cistern I was talking about was every cranial nerve, most of the cranial nerves. So that is the cistern going like that. So we'll just fast forward. So this is the anatomy which you have to be careful. So learning the anatomy around the tumor which you are going to operate is a key step, and that's the key step to avoid complications. So the tumor around here and a tumor coming from the clinoid or from the tuberculum here, when you cauterize that drill, some of these nerves can get damaged, especially around the falciparum ligament. You're operating near the tuberculum meningioma and you are cauterizing the base here. You see, part of the nerve is only covered by dura. And then if you cauterize it, you potentially can damage the optic nerve. Same as here as well. If you drill off the clinoid, and if you're not careful with the drilling, the heat can get conducted to the nerve, the oculomotor nerve, which just passes under the clinoid, and then the patient can get a palsy from it. Okay, so we'll just skip it. So that is the okay. So the other key point about the meningiomas arising from the clinoid, it's essential that you learn the anatomy of the anterior clinoid process. Learning the anterior clinoid process and its anatomy is a key step in managing these meningiomas. As you know, there are critical structures. The carotid artery curves around the medial aspect of the anterior clinoid process, and the optic nerve is also passing just in front of it. And the knowledge of the optic strut and the roots of the anterior clinoid process is essential to deal with these meningiomas. We'll see some of them. And one thing I would like to emphasize in these sort of tumors is that if you look at the origin of this tumor, the epicenter of the tumor, you can see where it arises from determines complexity. For example, you can group these clinoid tumors into different groups, but the common is to classify them into three groups. The group one often can arise from the medial aspect of the clinoid, then it can encase the carotid artery. See, the carotid artery becomes an intracranial structure beyond the distal dural ring. And sometimes the arachnoid can extend into the carotid cave. Sometimes it may not extend all the way down to where it becomes a supracranial component. There may be a millimeter or two part of the carotid which may be without arachnoid layer. And if a tumor then develops and encases the carotid without really having a carotid plane between the carotid, we can imagine the carotid, it grows around the carotid, even in case it invades into adventitia. And these are very difficult tumors to operate. But they can always, when they grow from here, they can push the optic nerve with their optic nerve cistern. So optic nerve dissection is not that difficult, but then carotid can be a determining factor in terms of the complexity. But likewise, if you have a tumor coming from the outside, it's not that difficult because it will push all the structures more medially, including the optic nerve cistern, the carotid cistern, and it is easy to dissect them off. A tumor coming there, another group of tumor that comes from more anteriorly and medially towards the optic nerve, that will not have a arachnoid plane between the optic nerve, and it will be difficult to dissect off the optic nerve at that time. But it may have a plane with the carotid artery. So these are the factors one has to think of. So this is another lady in 2012. I operated her, and this is a clinoid meningioma. Again, this is a kind of clinoid meningioma which has got an arachnoid plane with the carotid artery. One has to follow the carotid artery here. Say that if you follow this tumor, the carotid artery, you can see it's growing. The tumor is growing it, but it's still preserving. It's not encasing it. It's higher up. You can see it is still. You can see the branches all there, but it is not really encasing it. If you look at this beautiful illustration here, the cisterns around the optic nerve and the carotid artery and sylvian fissure, these cisterns will get pushed away from, pushed medially by the tumor. So that is your safe plane. So it wasn't, it is not that difficult as long as you're careful about the dissection. For example, this one, I think she was operated in 2010 when she came with a large tumor causing a lot of pressure symptoms. If you look at this tumor here, this is right in the clinoid where it encases the carotid. There is no arachnoid plane between the carotid. And you can see the way the appearance of the pedicle is, where this blood vessels supplying the tumor. And that makes it really difficult. And when this is when one will have to do an angiogram to determine the extent of encasement of the carotid, and also to assess the collateral circulation. You often can injure the carotid, and you want to know whether the patient can survive without that carotid. And also the other thing one has to study the angiogram is for the venogram. So this carotid, you see, it's all tapered here, and obviously tumor is encasing it, it's narrow. But you see this, the basal ganglia perforator here, it's like a sprinkler, with a perfusing all the basal ganglia. So that's a critical perforator which you will have to protect at any cost. And obviously, tumor is also being supplied by some branches of it, and even the middle meningohypophyseal trunk is also enlarged here. I'll go faster. So see, this tumor, this is typical appearance of the meningioma, by the way, and some people have described this as saying, the blush comes in early and stays late. You may have heard of that expression before. But the crucial thing about this meningioma is that if you look at the opposite carotid circulation, the ipsilateral, the left side hemisphere is also supplied by the ACOM and from the other side and supplies the hemisphere. So that ACOM, here you can see that ACOM. Where is that ACOM? That ACOM and the A1 is inside the tumor. So that is critical. So that vessel is also supplying this hemisphere. Carotid is a no-go area in this tumor, and as well as the A1. So this is something which we'll have to protect in these sort of tumors. Here, it is a very sensible thing to leave tumor behind without adventuring, without taking more risk. So this is when you have to know when to stop. That's when the experience comes. And she did have radiotherapy subsequently. She scanned 3 years later and stable. So, okay, well, we'll look at some of the convexity meningioma. These are the best tumors to operate. Everybody wants to operate these tumors, but when can it be complex? we think it can be a standard operation, and we all love to operate this convexity meningioma. But you have to look at the additional factors to determine complexity. Look out for the supply from the internal carotid artery vessels, or the parasitization of blood supply, and also the venous relationship can make it more complex. Let me show you one case some years ago. So is it a complex tumor or a straightforward standard convexity meningioma? What all things you can get from this picture? One thing for sure, that it is very vascular. It's fairly big and causing a lot of mass effect, but this is a convexity meningioma. But also, the other thing you notice here is the amount of necrosis. That indicates that it's a tumor which grows very rapidly. So the proliferation of the tumor is high, which also means that it's taking a lot of blood supply as well. That also tells you something that it's got a very vascular structure. So I'm just going to skip through. So you see, so this is the pedicle here, but also you see a lot of vasculature around it. So would you do an angiogram for this case or not? This is something which can give you some information. Normally for convexity meningiomas, I don't tend to take the risk of an additional morbidity from an angiogram or using embolization, most convexity meningiomas. But if you look at the angiogram, these vessels are supplied by the middle meningeal artery. What you see, the sinuous course is the superficial temporal artery. Normally they don't supply this. Sometimes they can have a transosseous feeder into the pedicle, but they are supplied by the middle meningeal artery. This vessel. See, this is the branch of the middle meningeal, and it's a posterior branch. And you can see the caliber of the middle meningeal retains the same. So normally you get tapering off the middle meningeal towards the convexity. Here it retains the same caliber. This is what you call in angiogram the paradoxical dilation of the vessel. But also the more worrying feature from an angiogram is the internal carotid injection, where you see a lot of supply from the middle meningeal and the anticipal artery branches. So this is not a good sign at all. So you've got to be extra careful when operating this tumor. These are complex tumors, and you can lose a lot of blood when you operate on this tumor. So this tumor, when I joined the operation, the blood was being bled. There was a lot of bleeding, and the patient had lost blood quite a bit already, and the anesthetist was panicking. So we had to do a rapid excision of the tumor. But then you know that the patient's got a lot of pile supply. So this patient then subsequently had a postoperative hemorrhage. Eventually, we had to do a craniectomy, and then this is him few years later. He did have weakness, but he could walk when he recovered. But his right hand was still in a sling, and the distal movements were very affected by the hemorrhage and this injury to the brain. So one has to be really careful even for convexity meningioma. What about the more intrinsic kind of meningioma? This is a choroid plexus tumor. Even though they look daunting, and they are not that difficult, just because they come from a narrow pedicle. So all you have to do, this is not where you can detach it first, the pedicle. Here you have to debulk it first and then go for the pedicle. So in the scan, you can see some ependymal vessels being engorged veins, which you see exactly what you see when you actually go through, go to the tumor. These are all sort of engorged veins on the surface of the tumor, but they are not difficult tumors to operate on. And the consistency wise also, they are not difficult often. And the other group of meningiomas, which one has to look at the way they are, the tendoral meningiomas. And this is where you have to decide on the position of the patient as well as the approach you're going to take. For example, a tumor of this location in the middle incisura bit, the question is whether you come from the side or come from the front, or some other approaches you have to take. So that determines. This is a man who was operated in 2008, a large tumor from the tendoral incisura, and the fourth nerve is at risk, as you know, when you operate on this tumor. This is one I operate through the subtemporal approach. When you operate on subtemporal approach, one key factor you have to look at the MR scan and the MRV is the vein of Labe. So that is one thing you have to determine. And these tumors will have some meningeal enhancement and thickening, and these tumors can recur. This is after a couple of years, the tumor started growing back. Then we again could go back in to resect it. But then, you always did have some enhancement in the anterior tendoral edge, and then we had to go for radiotherapy. So olfactory groove meningioma, another common operations we do. One key thing which I will remind is the position of the head. You want the gravity to assist you. You have to tilt the head downward to get the basal approach. And you can decide on unilateral, bilateral, and depending on your preference, and also the extent of the tumor. The one point which I would mention is the size of the tumor. When you have a large tumor like this, it's in a way, they are big tumors and they can be very difficult to operate. But also, when you remove the tumor, you have plenty of space, and the swelling that comes after, the brain swelling that comes after will be accommodated. But when you operate from medium-sized tumors with a lot of edema, that is when it can be tricky. When you retract the brain and then the tumor space, the resection cavity is not that big, and then there might not be much space for the brain to swell up. So they are the ones you have to be really careful about. Small tumors, you don't really have to retract too much of a brain to get to it. This is a lady who came to us several years ago with an hemorrhage in a large olfactory groove. The pedicule, as you know, comes from the ethmoidal branches of the ophthalmic artery. So they're not that difficult. So I'll skip through it. And this is another topic by itself, where the planum and tubercular meningioma, how do you approach transcranially or endoscopically, and which side you choose? You go through the same set of approaches. These are things you have to think about, and also study the CT scan very carefully. Not only for these sort of skull-based meningioma. The few things I look for, especially when I do front orbital craniotomies, what is the extent of the air sinus? If I can just miss the frontal air sinus and avoid breaching the sinus, I would do that. Orbital roof, whether you need to drill off the orbital roof if you are doing a subfrontal approach. And the other thing is the erosion and hyperostosis of the bone. That gives you a clue whether you may have to prepare for a cranioplasty. And clinoid we talked about. You have to know the anatomy of the clinoid. And the clival bone, study the anatomy of the clival bone on the CT scan, especially for endoscopic operations for clival tumors. Petrous bone and petroclival meningiomas are something which is well known about, and condyle for paralateral approach. These are things which you look for. This case operated at least 7 or 8 years ago for an endoscopic approach, but they are not difficult tumors at times, but there are only selected group of meningiomas I would operate endoscopically these days. And one has to know the system they display, and it makes sense to come from below for some of these tumors, because you'll be detaching and devasculating the tumor from the beginning when you come from below. But not all of tumors are suitable for that. You can see the cisterns that will displace these tumors. The tumor coming from here will push these cisterns up. So this man actually was a porter in our own trust, operated in 2018, came with a visual pale optic disc. And you can see the tumor will push this optic cistern and optic nerve up with the cisterns around it. And this is the one I did through a lateral approach, frontolateral approach. You can see the cisterns will be preserved around the optic nerve here. Just to orient yourself, you're seeing the right carotid artery be under the optic nerve and the left carotid artery here. This is the optic nerve under it. So these cisterns are well preserved, and that will preserve your important vessels to your chiasm as well, the branches of superior hypothalamic artery, hypophyseal artery. And another one, initially she became, had a progressive visual loss from this tumor during her pregnancy, but wanted to keep her pregnancy, and then went on to have surgery after her pregnancy. Initially, they did it endoscopically and found that the angiocerebral arteries were severely adherent to the vessels, to the tumor. This is then subsequently had to take her back to theater 3 months later to dissect off the artery. You see, this artery is intimately adherent to this tumor. Tumor is a firm structure. It's not really a soft one which you can suck out. And in spite of this approach, I just could not really separate it. And then eventually had to leave a little bit of rind of tumor on the artery. But you see, when you dissect off these arteries, in spite of leaving the remnant, you can see a little bit of remnant which I'm watching. But the orbitofrontal artery shows some ischemia. The medial frontal hemisphere shows some ischemia. But there was no clinical difference at all, but this is what happens when you try to dissect it off. And these tumors, the sphenoorbital meningiomas, another one where you have to study the CT scan carefully. You have to study how much of the ridge is expanded, and whether you have to drill off the clinoid. These are things which you have to study as well. So MRI, one thing one may be useful is to look at the T2 signal. There is some correlation between the nature of the tumor, the consistency of the tumor, and the signal in the T2 weighted. Sometimes when you have a high C2 signal, it may be more soft and suckable, and that makes surgery so more easy. But there's not a correlation all the time, but there can be. And a few other factors which we have to look for, especially parasagittal, the venous anatomy. Sometimes you may have to take a contralateral approach through the forks to avoid the veins. And veins are critical. And in fact, veins are so critical in meningioma surgery that you take every precaution to avoid injuring them. Because the reason is when you have resected a meningioma, if you have injured the draining veins, the vessels you have cauterized can subsequently cause postoperative hemorrhage. So many postoperative hemorrhage I have witnessed over a number of years are related to venous damage. So I think I will be stopping soon. One more thing which I have to show you, and the approach, especially this clival meningiomas. Our traditional approaches use are sort of far lateral approaches in a condyle resection and extralateral approaches to get to the anterior part of the brainstem. But one key principle one can, if possible, is to avoid traversing those planes, and which you can get by an endoscopic approach. And this is where you have to study the clival anatomy very well. This is the drilling of the clinoid between the carotid. So when you know where the carotid is, you get as much window as possible for your clival drilling. And so the tumor is soft here. So it's really lucky to have this sort of tumors through this approach. Otherwise, you don't have much space to. And got to be careful about these perforators from the vertebral artery. And there's no way you could try and put more traction on it, because once it ruptures, it may not be a good day for you. And here, you're leaving behind some remnant. Remnant is not a major problem, because this is a man who was in his 70s, was going off his leg from the brainstem compromise, and this is going to remain stable. And if it goes back, you can often consider chirurgical radiosurgery for it. So finally, I will end my talk with some of the points which I have gone through in this talk. You really have to study the tumor carefully on the scan. Look at all the features you may think of from the scan, CT scans and the MRI scans, angiograms, even X-rays. The one other thing which I often tell my trainees is to have a 3D X-ray vision. That is where all the courses and the cadaver, you have that kind of imagination. When you look at the patient's head on an operating table, when you want to position the head, you need to know what you will be seeing when you go through the structures, and then you can position the head appropriately. And the other thing is, especially for the juniors, that when they start craniotomy, they will not care about the bleeding from anywhere, and they just wanted to get through the craniotomy as fast as possible. But I will not recommend that. I think you just have to preserve as much blood as possible, and then try to avoid a lot of bleeding during the scalp opening and craniotomy, because some of these meningiomas can bleed torrentially, and you don't want to end up in a situation where you have a bleeding diathesis from coagulation factor failures. So you've got to preserve any blood you can. And the ligation and meningeal feeders is a basic thing. Dural opening, got to be careful not to injure the veins around it, and open only the dura which you think needed for those meningiomas. Venous injury is very critical. Avoid the venous damage at any cost possible. But I know that it's in some situations not possible, especially in anterior third. You may have to, especially doing an interhemispheric or a Fox meningiomas. We talked about this. I think that's where I'm going to end my talk, Imad. Thanks very much. Thanks, Imad and Salman. I'm happy to, yeah.
Thank you, Ramesh. There was one question from Morocco, from Mohammed, asking about how you to avoid excessive edema post-operatively in meningeal resection.
Yeah. So I think I briefly mentioned about the size of the tumor and the reading the scans beforehand. But the crucial point about avoiding swelling of the brain after this sort of operation is two things. One is your retraction of the brain, especially skull-based meningioma with which we have to retract the brain, you have to make sure that you're not putting a lot of retraction on. And the best thing will be, if you can avoid retraction, that's the best thing. Instead of a fixed retractor, we can have a dynamic retraction. Whenever you see a suction and at times you can retract it, then that is the best thing. Then you're not causing any ischemia to the brain that can swell up later on. And the second point is the venous structures around it. And the crucial thing is to preserve any venous structure you may encounter, and veins draining the area where you're operating. And if you have taken them out, there's no other place for this swelling to go down. Won't be any circulation. There will be congestion that tend to cause swelling. And there are other factors as well, but these are the two main things.
So Salman, are we going with the time?
We are
show a couple of slides, or you want to conclude, whatever.
I think we have multiple choice questions from Adrian, which we can see from his talks. And if there's one question from Mohammed Rakib, and I will unmute him, and you can take it from there.
Right, thanks.
Yes, Rakib, you want to ask a question? Sorry, I think he's gone to have break his fast or something. So anyway, so yes, Imadullah, are you there? Imadullah has disappeared as well on us. Maybe Imad, you want to show your slides, maybe?
I just want to give a couple of slides.
Yes,
if Ramesh allow me to follow his nice presentation.
Thanks, Imad.
Yeah,
Thank you.
Yeah, I will share my screen. I'm trying to get the full screen. And yeah, you see some of the slide that I'm just hinting few things on the supracellular and diaphragma cellular meningioma that Ramesh has covered partially of it. Of course, the classification made by Al-Mufti and Pamir was an excellent classification. You hinted nicely about it with the presence of arachnoid plane, the group 1, which is the lower clinoid. This is where you might have no arachnoid. This is where the risky dissection of a meningioma in that area, anterior clinoid, where the others, they are more feasible. Talking about transsonical, I might consider only the one of the diaphragma celli that is originated from the lower leaf of the diaphragma. And this is where you can safely take this meningioma per endoscope rather than the one coming from the supra leaf from the diaphragma celli. Most of these diaphragma celli, they have some extension into the optic foramina, and usually it can be in 30% bilateral. I have operated of a couple of them. They was not shown nicely on MRI, but in situ you see there is a tumor tongue. This is where the value I feel in tuberculum cellular meningioma. I'd like to open the optic foramina to take the tumor early enough to decompress the optic nerve, because if you leave it to the end, the manipulation of the tethered optic nerve might lead to ischemia. And I'll show one picture. This is the 5D concept I have introduced, Ramesh, 6 years ago, and it's published specifically for meningioma, but for supracellular. You see, I talk about drilling the sphenoid ring is essential, because if you have the bone balcony, your retraction will cause the trouble. And the roof, the optic nerve, devascularize, as you mentioned, decompress the tumor. There is an inclination, especially of a giant convexity meningioma, this ego of neurosurgeon to take it in one piece, put the stitch and pull on, and you have it out. This trend, I am moved away from it. I still devascularize, do a central debulking of that lesion using whatever the instrument, and then you can deflect the capsule inward in the tumor cavity you have initiated, rather than to pull on the edematous brain. This is the value, that slide I put it. You see, when you take the sphenoid wing, any lesion in that area, you have only 1 centimeter to reach. And that's what makes me, several years ago, to abandon the bifrontal approach that we acquired usually from famous pediatric neurosurgeons. They like to have the bifrontal approach. Perhaps the tolerance, the resilience of the frontal lobe of a child different than elderly. But it has many disadvantages, the bifrontal, where the unilateral approach is still the what I call it, the power horse of the anterior lateral approaches, because you don't damage two frontal lobe, you don't hammer bridging veins, you don't deal with sinus, you see the important anatomy you are concerned about, optic nerve and vascularity at the back. By bifrontal approach, you see it at the end, where in this approach, terional, you see it early enough. So you have a control, you have the command. And arachnoid, you mentioned it, is very important. And the deroofing of the optic nerve, this is one case pre and post. You see the advantage as the brain not touched. And this is another one, you see the post-pericallosal artery from unilateral approach that was not encased. They could be dissected nicely. This is post-resection as the brain was not touched. This case was a difficult case. And I put it to show the anterior clinoid can be very difficult. It's not an easy task. And you see where the carotid and the middle cerebral artery inside the tumor. The problem is not only the major vessels, the problem with the perforators. And this is where the risk of this surgery. So using Doppler is important in this case. That approach fronto-orbitozygomatic, we abandoned using it slowly, except with the cavernous sinus surgery, perhaps in some giant anterior clinoid like the one I showed. But that approach has been quantified by Andalus 1986, and it shows the value. But we, I think, come along enough with the pure terional and the flattening the orbital roof. So vascular complication, as you mentioned, I was happy that you showed some angiographic picture. This is, I think, a quiz for the new trainees. They have never seen it. I've seen that angiogram, the first one from 2010, and the other one from 2012. So 10 years ago, it was an essential part, because until today, we don't have selective MRI angiography. These studies you showed, they are selective. If they need to embolize or to understand the vascularity very well, they were of value. And I don't know, I'm not using anymore the angio, but it was a golden time where the angio has shown a lot of information. I think I am done, and that's what I want to say and share with you. I leave it to Salman to make that final.
Thank you, Imad. That was wonderful. I think those tips that you gave, I've seen this talk before and enjoyed it before, and it's good revision for me, and I'm sure it's great for all the trainees over there. We're just going to go through the multiple choice questions that Adrian has left for us. He's here to step away to Operation Theater. Adrian, are you there? Are you gone? I think he's gone. So these are the questions, and Ramesh, you have to answer these questions. Wake up. Ramesh, are you there?
Unmute myself. Let me unmute myself. Okay, let's read the questions. Okay.
Yeah.
So, which is the most common neuroendoscopy complication leading to permanent neurological injury? Sudden increase in intraventricular pressure, injury to fornix columns, mammillary body injury, basal ganglia injury, and third nerve injury during ETV. For me, I would say it's probably the injury to the fornix column, which is probably more common than the others, and it's likely to be can lead to permanent damage if you injure both. I don't know what you think, Salman.
Yeah, I think I agree. We will see the answers below. So let's go down. You can read the questions, and we can see the
I
answers.
can't. I don't know who's you sharing it or who. Okay, well, I can't really scroll it down.
Madullah is sharing it. Yeah.
Okay. So the next question is: which is the best way to fenestrate the third ventricle tuber cinerarium? Why should you penetrate towards an area. That's my okay. Using bipolar electrode, using monopolar electrode, using lens of the endoscope, using Fogarty neuroballoon, or using endoscopic scissors. Among these options, I would probably go for the monopolar one. Would you?
Yeah. Okay.
Yeah. Okay. Let's scroll up. Imadullah.
Third.
Yeah. Scroll down a little bit more.
Imad, can you take us down to third? Imadullah, please. What happened? Hello, Imadullah.
I can. Okay.
Yes,
Well,
sir,
You have it.
I think a bit internet issue.
all right. So the third question is, which is the best way to manage chronic subdural hematomas in infant following endoscopy? Transfontanellar serial taps, Burholtz, subdural peritoneal shunt, craniotomy with excision of vessel membrane, and chirotherapy. I probably would go for that repeated aspiration. I don't know what you think, Salman.
I think in kids, yes, repeated aspiration does work well.
Okay, the fourth one will be following injury to basilar artery, which spontaneously stopped. What is the most frequent complication? Pseudoaneurysm, moya-moya-like disease, diffuse vasospasm, uncontrollable arterial hypertension, and diabetes insipidus. I would go for pseudoaneurysm then.
Yeah, agree.
Okay, let's go. Scroll down, Imadullah. Okay, which what is that? Which
IV solutions.
IV solutions are safe to be used in neuroendoscopy for ventricular irrigation? Homosaline, 5% dextrose, ringer lactate, distilled water, 1 and 2, 2 and 4. Is that 1 and 2? Maybe 1 and 2. That's my choice.
I like the ringer.
Ringer lactate is actually the best.
This is the
but
ringer is like your own CSF.
Okay, let's scroll down. Yeah, I think I agree. I think.
Okay, let's see the answers. Can we see the answers?
So you have all. So which is the what is it? Commonest.
Most
common. Injury to the fornix. Yeah, that's correct. Okay, let's go scroll down. Which is the best way to fenestrate a third ventricle? That is using. Okay, it says Fogarty or neuroballoon is the best way to fenestrate the flow. All right.
I think different people's opinion. Yeah.
Okay, let's scroll down. So the best way to manage chronic subdural hematoma is serial taps. Okay, that's fine. Okay, then good. Scroll down again. Yeah, let's see the fourth question. Yeah, following injury to the basilar artery, what is the most frequent complication? So pseudoaneurysm. Okay, that's fine.
Good.
Next one. So IV solutions. The good is normal saline is good. Not much of a dextrose and ringer lactate. So IV saline and ringer lactate, but I don't think that choice was there.
Yeah, he didn't give the choice. He just taught us that you can use saline as well besides ringer lactate. Okay, that's great.
Thanks.
And this is quality of evidence and how your evidence was.
So what is those down? Two charts? So 149 response.
So 149 people filled these, and they said that your quality of evidence was either excellent in 73% and good in 23%. 5% thought it was average. And then quality of content, same, go down. Overall presentation, again, same, and excellent and good in 96%. Would you like to hear this presenter again? Yes, is what 100% said that they want to hear you again.
Yeah, that's a relief.
So, so that's a relief for you. Imadullah, do you have our next couple of days program in front of us? You can show us while in the meantime. Okay, so we have tomorrow rotor neuroanatomy course. So it's module 1. We have the session 4, which is on fourth ventricle, anatomy and approaches. And we have 2 of our chief residents presenting. And supervising them is Azam Ahmad. Sorry, can we go back, Ahmad? Ahmad, can you go back, please? Supervising them would be Hassan Sayed. They're both from US, and Chandrasekhar Pujari from Mumbai. Next, please. And on Friday, we have Hassan Zaidi from Brigham and Women's Hospital in Boston. He's going to be talking about scoliosis surgery and deformity surgery. And Onur Yaman from Istanbul will be talking about sagittal balance, and moderating that session will be Doug Orr from Cleveland Clinic. So that's what we have, I think, and for next few days. And we'll hope to see you again. Professor Ahmad, would you like to say a few words before we close?
Well, it was a nice experience to join this group and for us, the friends. And I was very impressed with the two talks, and I'm sure you have a great success for the future topics.
Thank you. We need your help always, you know that. Thank you. Thank you for supporting us. And Ramesh, would you like to say a few words when we wrap up?
Thanks, Salman, for this invitation. I think it's a great initiative taken, teaching everyone around the world, almost more than 200 to 50 on a regular basis. And it's a great initiative, and I'm more than happy to support, give you any support you need from my side. And thanks, Imad Kanan as well. It's been a great educator.
So I think Professor Ahmad Kanan will be giving us a talk in a fortnight or so, inshallah. And Ramesh will be moderating one of the sessions in next 10 days or so. I think I saw your name as a moderator somewhere. You'll find out the time. And
yeah, if you let me know in advance, so I will.
Okay, thank you, everybody. And I think it was great talks. I enjoyed them. I learned a lot. Sorry for taking a lot of time, but I think we all learned a lot. I'm grateful to everybody, and thank you, Professor Ahmad, for moderating, and Ramesh and Adrian for great talks. Thank you. Bye-bye.